Thank you very much indeed to Duru and her colleagues for involving me in this very interesting meeting and asking me to talk about hormone therapy, selecting the best protocols. And I'm going to use hormone to extend beyond HRT. I'm going to talk about the use of other types of sex steroid therapy, i.e. the oral contraceptive pill and other progestogens during the perimenopause and postmenopause. Now, I have no significant conflicts of interest, the last one being 2018. And what I'm going to be talking about are women with PCOS. And I think I really don't need to tell this audience that menstrual irregularity is common. It occurs in 60, 70%. High BMI is common in at least 50%. And metabolic abnormalities are common. And these were data from Professor Shah's own unit in Mumbai, and just give a good lead in to the sort of things we have to consider when looking at hormone therapy. Now, from a perimenopause point of view, what it often means is that women with PCOS will have a high risk of chronic anovulation, dysfunctional uterine bleeding, and endometrial hyperplasia. And so I'm going to talk, bringing these features into the presentation from time to time. The other thing, of course, is that in those who are obese, they have a much greater chance of having endometrial abnormalities. And this is really important in our deliberations. Now, let's think about the constituents of hormone replacement, whether the pill or HRT. I'm going to talk about HRT to start with, and this is estrogen treatment. And I want to just focus really on the different types. I've got tablets, i.e. oral treatment at the top in black. This is subject to first pass metabolism and will influence metabolic processes within the liver. And this may be good in some instances. It alters lipids to a varying degree, depending on type. And so may be useful. Gels and patches are given by the transdermal route, and together with nasal administration and implants are not subject to hepatic first pass metabolism, therefore less impact on biochemical processes. I've got the pessaries and vaginal tablets, etc., on the right-hand side of this image. I'm not really going to consider these further. They don't impact systemically very much. Now, I don't know that you have nasal administration of estrogen yet, but if you do, a lot of what I'm saying regarding either gel or patches will be covered by nasal. Now, oral estrogens in HRT are usually based on either conjugated equine estrogen or Premarin or estradiol 17 beta. Estradiol 17 beta is the hormone you produce from the ovary in the reproductive years and is rather more natural to a woman than equine estrogen, which is very natural to a horse, of course, and is a very complex set of estrogens, which have different potencies. And so it has somewhat different effects. In the oral contraceptive, the predominant estrogen is ethinyl estradiol in an overwhelming majority. It's a potent estrogen. The aim is to inhibit ovulation. So you need potent estrogens to be involved in that process. There are some newer preparations with estradiol 17 beta. Not sure if they're available in India as yet. Estrogens work for any symptoms related to the menopause due to lack of estrogen. And obviously the cardinal one is vasomotor symptoms. This is a very simple image I've shown many, many times before, because it's so obvious that placebo at the top and then the treatment doses at the bottom Estrogen works. It also helps bone and joint pain, and often feelings of well-being, mood changes, and many of the other symptoms of the menopause. Really, really useful. However, women with a uterus need a progestogen because unopposed estrogen stimulation of the endometrium is not good news. And the progesterone and progestogens impact very significantly on the HRT preparations and the pill. Now, progestogen compounds are based on three things. Progesterone, where you've got micronized progesterone now available orally, and dihydroprogestin, as you can see in the top. And then 17 hydroxyprogesterone derivatives, MPA, cyproterone, megestrol acetate, and the 19 nortestosterone derivatives, which are based, as it says, on testosterone and are so much more likely to have some androgenic properties. These need to all be taken into account when you're considering on the preparations you want to give your patients. Now, progesterone is the only naturally occurring progestogen, and all progestogens have anti-estrogenic, anti-gonadotrophic properties by definition, and they differ in their affinity for progesterone receptors and side effects. Progestogens will decidualize the endometrium, and it's a hugely important effect that they have. At the moment, only synthetic progestogens are used in oral contraceptives, although one, I think, has been developed and licensed in some countries that contains the micronized progesterone. Now, let's think a bit about some of the biological activities of progesterone and progestogens. This will help you decide what you want. If you want something which is not androgenic, you will go for progesterone, dihydrogesterone, something that's at the top of this image. If that isn't really that important, and some of the androgenic properties, for example, endometrial effects, as I'll come to later, are the most important, then you look at northisterone, levonorgestrel, dienogest, anti-mineralocorticoids. Then again, this could impact on blood pressure, and you'll look at the top progestogens. And then in the middle, you've got a slight mixture of effects. So this is a useful slide. And on the right-hand side of a similar image, you've got some of the conditions where you'll be wanting to think about using particular preparations. For example, hirsutism, you may well go towards progesterone. And then with the metabolic effects, you may go for something like drospirenone. And the breast cancer, there are some data on differences between the different types of estrogens. Now, let's start with bone. What I want to show here simply is that the progestogens have different impact on bone density. And this shows, to start with, conjugated estrogens and placebo. So as you all know, the effect of estrogen on the bone is without doubt. Now, does this happen with the estrogens as well? We did some studies years ago with GnRH agonists looking at progestogen add-back therapy. And you can see here, the purpose of this slide is purely to show that medroxyprogesterone acetate has absolutely no effect on bone density. If that is important to you and your patient, do not use preparations containing MPA, but use a preparation, for example, that contains northisterone, which is the progestogen showing in this slide that actually helps protect against bone loss. And so really, really important. And you can tailor your hormonal preparations, both pill and HRT, to be what is suited to the woman in question. So let's look at the combined preparations. Now, the aim of the oral contraceptive pill is to suppress ovulation and have a balanced effect on the endometrium, so it just bleeds on withdrawal, gives a really good bleeding pattern. There are now pills which are licensed for use in heavy menstrual bleeding, and I've got a little bit of data on one of them in a minute. However, first of all, side effects of the estrogens in relation to the pill, very important, and that is the increased risk of VTE in older women and also in obese women. And you can see it illustrated in this slide. However, if you are giving an HRT preparation, you can potentially get round this by using a transdermal HRT, which does not have any significant impact on the baseline risk of VTE. And this, I think, is a very neat little image which illustrates that point. And so you may well want to think about, for HRT, giving transdermal to high-risk people. What does it do to breast cancer risk? Well, the pill has no real impact on breast cancer risk. But, and so I think we now feel that it can be used very well up until the age of certainly of 50 in a woman who's non-obese and has normal blood pressure. The concerns being potentially cardiovascular disease, thrombosis, and the VTE risk. So think about this when you're thinking, what am I going to give to a woman, for example, who wants contraception in the perimenopause period, maybe getting some symptoms of the menopause and needs some hormone replacement to regulate her hormones. So are there more suitable pills for older women? Now, if we look at this particular preparation that I mentioned that is designed to help decrease heavy menstrual bleeding, and the way it does that, in fact, is by having a sequential constituents to try and mimic the menstrual cycle. And you can see in the right-hand part of this image that there is a reduction in menstrual blood loss of a significant level compared with placebo, and it compares reasonably well with the Mirena, as I will come to later on. Possibly better than other pills, but I don't think these data are very robust. Now, this slide is particularly just to illustrate that the different types of progestogen have a different effect on bleeding pattern. Now, drospirenone, which is the lilac-colored columns, is a progestogenic progesterone. Normadinone acetate is not, it's androgenic. However, when you're looking for an impact on endometrium and menstrual abnormality, you would tend to go for the androgenic progestogens, unless there's a strong reason for not, because it has a far stronger impact on the endometrium. The number of bleeding days, not that significant really, only 1 or 2 days different, but there still is some difference. And the irregular bleeding and unscheduled bleeding with the progestogenic containing pills can be quite a problem. Now, these are the pills that are available in India. Now, this is a slide about 2 years old, and I apologize if I've missed any new ones. Basically, 30, 20 milligrams of ethinyl estradiol, and then lots of different progestogens I was relieved to see. So you've got quite a good variety of different types of pills. Now, I think something else you must think about in your PCOS women, particularly those with anovulation in the past and who are obese, is the impact on endometrial cancer. Now, when you're thinking about progesterone, many people say, oh, progesterone is the answer to absolutely everything, but it isn't, I'm afraid. The top part of this slide shows estrogen alone, and you know those data very well. In the middle, you've got micronized progesterone with estrogen, and 95% confidence intervals indicate there's a significant increase in endometrial cancer after 5 years of use. And these are data from Fournier et al. From the E3N study. And the same thing with dydrogesterone. It does not have the same protective effect on endometrium. Now, when we're thinking about breast cancer, we also will want to know what the different progestogens do. And a lot of the data actually suggests that with prolonged use, there may be an increase, although it doesn't seem to be significant, according to this particular study from Fournier et al. However, when you look at the different types of HRT, and this was a publication from last year, you will see a slightly different pattern. You'll be aware of the increase overall with estrogen, progestogen. And then if one looks a little more precisely, you will see the different types of progestogens when combined with estrogen. MPA, significant increase. Levonorgestrel, significant increase. Down the bottom, dydrogesterone, with very prolonged use, maybe, but it's not statistically significant, or it's only just statistically significant. So there is a difference, but I think it's something one has to be a bit guarded with the patients when you're discussing. So options will be affected by obesity and also the age of the women in questions. So you may want to give the pill for those who are very keen on contraception, or you may think about progestogens. Now, these are hormone. These are given cyclically to treat heavy menstrual bleeding. You will need to inhibit ovulation and give 21 out of 28 days, or you can give progestogens using implants and injections. And these can be quite useful, often associated with irregular bleeding, but the protection of the endometrium against endometrial abnormalities is very, very high. And I think empirically, we do sometimes combine them with estrogen replacement in women wanting contraception and watching things very carefully. Now, one of the answers to many of your problems, of course, is the intrauterine system. It's fantastically useful all the way through the perimenopause and into the postmenopause. It has very little metabolic effect. It's more effective than the combined hormonal contraceptives and can be used for various pathologies as well. And it protects the endometrium. So it's a great, really great preparation. I used it a lot in women with heavy menstrual bleeding, with small fibroids or normal cavities. And it was a great contraceptive. And then as they hit the menopause and got menopause symptoms, we were able to add in estrogen. And that was a tremendous benefit. And we know from studies done around the world that it is effective in many different ethnic groups and environments. So when you use the contraception, actually you can use it for a long time before needing to change it. This becomes a disadvantage in older women as they go into the postmenopause, and many want to keep using it. The size makes it more difficult to get in. But there are newer systems being developed which will be useful. And then when used as part of an HRT, the license is for less time. But to be honest, that's purely because of the length of the studies. And so in the main, our Faculty of Sexual and Reproductive Health advise that you can leave it a bit longer. And so you sort your woman out very well. And what you would do in this instance is to combine it with a transdermal estradiol of some sort. That is the optimum, because there's no metabolic effect, no impact on any of their metabolic processes or their DVT risk. So when you've got women with PCOS, obesity, anovulation, metabolic abnormalities, you can tailor whatever you give them to their needs. You've got the impact of estrogen type, oral versus transdermal, impact of progestogen type with progestogenic versus androgenic, women needing contraception, and women wanting symptom relief. So think about all these things and give individual treatment. I've not talked about the COVID pandemic. I'm not quite sure how I managed to miss it out, but I apologize for that. You will need to use PPE when you insert a Mirena, and that is the disadvantage of using the Mirena at the present time. But standard HRT preparations are much, much less useful for treating abnormal uterine bleeding. They just don't have potent enough steroids in them. So I apologize for missing that. This is a slide advertising our Congress, and I hope lots and lots and lots of you will be joining us. Thank you very much for your attention.